Cardiac embryology begins very early, and the heart becomes the first functional organ system in the embryo. Development starts with cardiogenic mesoderm, which gives rise to the primitive heart structures, and by about the fourth week, the heart is already beating. From that point, normal anatomy depends on a few major steps occurring in the correct sequence: formation of the primitive heart tube, looping to establish the right-left spatial arrangement, septation to create separate chambers and outflow tracts, and then the fetal to neonatal circulatory transition at birth. Most congenital heart disease can be understood as an error in one of these steps. Problems with looping can alter position. Problems with septation can create abnormal communications between chambers, and problems in outflow tract development can produce major conotruncal defects. Understanding the normal sequence makes the pathology much easier to recognize and remember. Early heart development begins in the cardiogenic mesoderm, where the cells that will form the heart are first specified. Two endocardial tubes develop and then fuse in the midline to create a single primitive heart tube. This tube is the starting framework for the future heart. Although it appears simple, it already contains the regions that will later contribute to the atria, ventricles, and great vessels. As development proceeds, this primitive tube lengthens, bends, and becomes partitioned into separate chambers and outflow pathways. The key idea is that the mature four-chambered heart does not appear all at once. It is built step by step from a single tubular structure, and many congenital abnormalities can be traced back to disruption at this early stage. Cardiac looping occurs during the fourth week and is the step that converts the straight primitive heart tube into the basic spatial layout of the future heart. As the tube elongates, it bends in a rightward direction, bringing the primitive ventricle forward and positioning the future atrial region more posteriorly and superiorly. This process establishes the normal left-right arrangement of the chambers and outflow tracts. The key point is that looping is not just a shape change, it is the foundation for normal cardiac anatomy. If this step is abnormal, the heart may be positioned incorrectly or associated with broader left-right patterning defects. Because this process depends on normal embryonic asymmetry, abnormalities in ciliary function can disrupt it and lead to conditions such as dextrocardia. Arterial septation begins when the septum primum grows downward from the roof of the primitive atrium toward the endocardial cushions. The gap below it initially allows blood to keep passing between the two sides, but as that gap narrows, a second opening forms higher in the septum primum, so interatrial flow is preserved. Then the septum secundum develops to the right of the first septum and partially covers this opening, leaving an oblique passage called the foramen ovale. In fetal life, this arrangement allows blood to move from the right atrium to the left atrium and bypass the non-functioning lungs. The important concept is that atrial septation creates both separation and a controlled fetal shunt, which later becomes important during the transition at birth. After birth, the hemodynamics of the heart change rapidly. Expansion of the lungs lowers pulmonary vascular resistance, which increases blood flow through the pulmonary circulation and returns more blood to the left atrium. As left atrial pressure rises above right atrial pressure, the septum primum is pushed against the septum secundum, producing functional closure of the foramen ovale. In most individuals, this later becomes an anatomic fusion. If fusion does not occur, a patent foramen ovale remains. This usually causes no major symptoms because left atrial pressure normally keeps it closed, but it can become clinically important if right atrial pressure rises or if a venous clot crosses into the arterial circulation, causing a paradoxical embolus. Ventricular septation begins with growth of the muscular interventricular septum upward from the floor of the primitive ventricle. This does not immediately close the space between the two future ventricles, so a temporary interventricular opening remains. Final closure requires formation of the membranous portion of the septum, which is produced by fusion of tissue from the endocardial cushions and the aorticopulmonary septum with the muscular septum. This is why ventricular septation depends on several structures working together. Clinically, this matters because ventricular septal defect is the most common congenital cardiac defect, and the membranous portion is the site most often affected. Endocardial cushions are central to partitioning the developing heart. They form in the atrioventricular canal and contribute to separation of the atria from the ventricles, formation of the atrioventricular septal region, and development of the mitral and tricuspid valves. They also contribute to the membranous part of the interventricular septum and help align the inflow portions of the heart. Because these structures participate in several parts of septation, cushion defects often produce complex malformations rather than a single isolated lesion. Clinically, abnormal endocardial cushion development is associated with atrioventricular septal defects and has a strong association with Down syndrome. The main idea is that these cushions are essential organizing structures in the center of the developing heart. Outflow tract formation depends on migration of neural crest cells into the truncal and bulbar ridges. These ridges grow and fuse to form the aorticopulmonary septum, which divides the single outflow tract into the ascending aorta and pulmonary trunk. This septum also follows a spiral course, which is why the great vessels normally cross as they leave the heart. The important point is that normal separation of the outflow tract requires both proper septation and proper rotation. If neural crest migration or septal formation is abnormal, major conotruncal defects can result, including persistent truncus arteriosus, transposition of the great arteries, and tetralogy of Fallot. So this step is essential for connecting each ventricle to the correct great vessel. Valve development occurs as the channels of the heart are being partitioned. The atrioventricular valves, the mitral and tricuspid valves, develop mainly from endocardial cushion tissue in the atrioventricular canal, while the semilunar valves, the aortic and pulmonic valves, form from cushion-like swellings in the outflow tract. As these tissues remodel, thin valve leaflets are created and connected to the surrounding myocardium in a way that allows one-way blood flow. The key idea is that valve formation is tightly linked to septation and outflow tract development, so abnormalities in these processes often occur together. When valve development is disrupted, the result can be stenosis, regurgitation, atresia, or malposition of the valve, depending on which part of the developmental process is affected. A useful way to organize cardiac embryology is to match each embryonic structure with its main adult derivative. The sinus venosus contributes to the smooth part of the right atrium, and its left horn becomes the coronary sinus. The primitive atrium forms the trabeculated portions of the atria. The primitive ventricle mainly gives rise to the trabeculated left ventricle, while the bulbous cordis contributes to the right ventricle and the smooth ventricular outflow tracts. The truncus arteriosus forms the roots and proximal portions of the aorta and pulmonary trunk. The cardinal venous system contributes to the vena cavae. Remembering these relationships helps make congenital defects more logical because when one embryonic region develops abnormally, the corresponding adult structure is the one that is affected. In fetal circulation, oxygenated blood returns from the placenta and is directed through three major shunts that bypass organs not yet functioning at full postnatal capacity. The ductus venosus allows much of the placental blood to bypass the liver and enter the inferior vena cava. From the right atrium, a large portion of this blood passes through the foramen oval into the left atrium, then to the left ventricle and aorta, helping deliver the most oxygenated blood to the brain and upper body. Blood that enters the right ventricle is pumped into the pulmonary artery, but because fetal pulmonary resistance is high, most of it is diverted through the ductus arteriosus into the descending aorta rather than going to the lungs. This arrangement is an adaptation to placental oxygen exchange and non-expanded fetal lungs. At birth, the circulation changes rapidly as the lungs expand and pulmonary vascular resistance falls. More blood now flows through the lungs and returns to the left atrium, which raises left atrial pressure and functionally closes the foramen oval. At the same time, increased oxygen tension and loss of placental prostaglandin support promote constriction of the ductus arteriosus, which later becomes the ligamentum arteriosum. The ductus venosus also closes once placental flow stops and becomes the ligamentum venosum. These changes shift the circulation from placental oxygen exchange to pulmonary oxygen exchange and establish the normal separation of the right and left sides of the heart. When these fetal channels fail to close appropriately, persistent postnatal shunts can remain and become clinically important.